therapy in 2021. Or you can call it, as Professor Mahmoode called it, 5 alive. These are alive and the rest are dead armamentarium. So AC inhibitor or ARB blockers, beta blockers, MRA, mineralocorticoid receptor antagonist, ARNI, SGLT2 inhibitor. Now you can see this in pictorial fashion. I have borrowed this slide from Professor Mahmoode's collection, and it is showing ACI inhibitor and ARB, beta blocker and MRA inhibitor. And on the top three, we have added neprilysin inhibitor as per I have shown you the paradigm heart failure trial, SGLT2 inhibitor, DAPA heart failure trial. So these are the five surviving people in the list. Now what is the change? What has happened in the modern system? Previously, we were just giving one thing, waiting for a long time to see the result, go slow and let the patient suffer, and the mortality was not getting reduced. But now the sequence of drugs have changed. This is the key to reduce the mortality. We must use at a time the SGLT2 inhibitor, ARNI and beta blocker at the same time in one line, as you have seen in Canadian recommendation of 2021. They all have additive effect on reducing mortality, but at the same time I must say that all conventional therapy to continue. You cannot just advise these things and sleep. All the conventional therapy as per the patient's requirement you must give it. Now, as we have talked a lot about beta blockers, I will share few points about the beta blockers. From my long experience, I have seen that we many times falter in using beta blockers. We must use judiciously. Start with the low dose, titrate upward, because we don't know the patient how he is going to behave. We must maintain the pulse rate between 55 to 60. Now it is very easy to do this because all the population due to COVID, they are carrying pulse oximetry. So in that they will check the oxygen at the same time. Pulse rate will be very accurately measured by that. We must see that the patient does not get postural hypotension. It has to be checked in the doctor's office, and it requires patience with the sphygmomanometer, mercury sphygmomanometer. It takes time. We should be more careful in diabetic patient because their hypoglycemic reaction might be delayed. We must exclude absolute contraindication before prescribing beta blocker. We must know the excretion of the route of the drug. Metoprolol is hepatic, bisoprolol is renal and hepatic. Equally, carvedilol is hepatic plus and renal is 1+. There are cases in beta blocker with slow genetic metabolism in the liver. In that case you can have a very high serum level of the particular drug, be it propranolol or be it metoprolol, or there are so many drugs. Metoprolol itself can be metabolized in 17 different types in the liver itself, and it can make the blood level to 50% higher than what is expected. So we must know these things. We must know the drug properly. We must know the patient properly before we give beta blocker and the benefit of the beta blocker. And in any drug, it is not only the beta blocker. In all cardiac drug requires a lot of study. But having said so, having talked about more than 30 minutes. Even then, nowadays, the treating physician will have clinical inertia, not doing things properly. He will call that my patient has got mild heart failure. Why should I bother? My patient is stable on current therapy. Why should I bother? Why should I go on beating around the bush? Why should I change anything? It is more inconvenient for him, that means patient. It is inconvenient for the patient to change the drug regime, and silently he thinks that it is more work for me. That means physician has to work more because it's going to change it. So he has to. These leads to rather substandard treatment in present scenario. By substandard means that what mortality benefit, morbidity benefit we are going to give to the heart failure patient, they are not going to get it if we show clinical inertia among patients. I think I will end at this point, and I will say thank you for the patient listening and really sharing these slides with you. And I like to take up any queries or comments because I am here to learn also from you. Thank you very much.
Thank you very much, Dr. Riken Singh, for this wonderful academic feast. It was really quite elaborative and very well poised in terms of evolving trends, showing the evolving trends in heart failure management. And the most important part was the elaborative take-home messages that you have given in your last 3 to 4 slides, that has really given a clear-cut direction to the audience that how to manage heart failure with the evolving drugs as well as with the conventional drugs available. We have some few questions, so with your permission, can we begin with questions, sir?
Yes, sure.
Right. So here is a first question, which is I feel is very important. Can beta blocker be used in heart failure with preserved ejection fraction?
Preserved ejection fraction is an entirely different story. Actually, for heart failure with preserved ejection fraction, beta blocker using will not reduce mortality. But at the same time, preserved ejection fraction will be suffering if many patients will be having high blood pressure. For treatment of the high blood pressure, you can definitely go ahead with a beta blocker in full dose, and you will prevent heart failure with preserved ejection fraction. And it is a very phenomenal thing that unfortunately we don't have any proved reduction in mortality by any of these medicines. So I would definitely like to take another CME on heart failure with preserved ejection fraction. I have a lot to comment and communicate with you. I can say one more thing about it. Last year in 2020, I shared my publication in European Society of Cardiology about heart failure with preserved ejection fraction, and the one proven factor other than treating the comorbidities of the heart failure with preserved ejection is your graded exercise. Graded exercise is a very important thing for the heart failure with preserved ejection fraction, because the dyspnea, the breathing difficulty which you get is not due to myocardial poor contraction, but because you have got so many comorbidities, your peripheral system, there is oxygen extraction problem is very defective. The mitochondria is not extracting proper oxygen. So if you do graded exercise, is going to really help the patient with preserved ejection fraction. But definitely I will say you can use it to treat the comorbidities, hypertension. You can definitely go ahead with the beta blocker.
spoke about usage of beta blocker in CKD patient or maybe in diabetes patient with heart failure.
Yeah.
Can beta blocker be used in heart failure patients with COPD?
No, COPD, you have to use beta blocker with caution always. The only drug you can use in COPD is bisoprolol with caution, because it is a zero effect on beta 2 receptor in the bronchial vasculature. And in low dose you can give metoprolol, but if you are using higher dose of metoprolol, it will have effect on beta 2 receptor of the bronchial tree. This is a recorded thing. And so I would say, if a patient is having COPD, you should use bisoprolol in a very low dose with the proper treatment of the COPD, if at all it is deemed necessary to give beta blocker.
Thank you, sir. Next question is, when one should use evapradine in heart failure management?
Heart failure, when your heart rate is not coming down, is not stabilizing beyond 65 beat per minute, if everything is okay and your patient is having tachycardia like 90, 95, 100, and patient is otherwise asymptomatic now, you have given the full course of the treatment, in that case only evapradine can be used. It has got a very limited role in heart failure for this.
Thank you, sir. Now, while you are already on the targeted heart rate, one of the question is, due to the sympathetic most of the young patients who are suffering with hypertension, in them the cause of hypertension is found to be sympathetic overdrive. So in that scenario, in that case, do you feel beta blocker can be used in young patients with hypertension?
Yes, sure. I always use with good result.
Right. The next question, sir, is, can you explain when beta blocker can be up titrated? How he wants to understand the dosage titration, how beta blocker can be up titrated?
Because suppose I start with the metoprolol, say for example 25 milligram per day, OD dose, a single dose. If the patient is having pulse rate say 70, 80, and the blood pressure is okay, then we will go to 25 to 50 milligram. Because we don't know the patient's liver function, we don't know how the metabolic system of the patient will behave. If everything is going okay and the pulse rate, when it comes to between 55 to 60, I will stop giving up titration. And at the same time, I will watch that the patient does not have postural hypotension by taking the blood pressure and standing and lying position. If anybody shows the postural hypotension fall of more than 20 millimeter of mercury after 3 minutes of standing, then we should be careful, because the sympathetic drive is probably at stake, and we should try to. This is more true in elderly patient. Their sympathetic system and autonomic nervous system is already compromised due to age, due to diabetes, due to so many things. In that case of elderly patient, I will definitely check for postural hypotension. And I have seen the patient coming to my office for checkup, and while walking to my office, many patient has just fallen on the gate of the my chamber due to postural hypotension. I checked that there is overuse of the drug is there. So I reassure the patient, recheck the postural changes, and I try to do justice for the ailing patient.
Thank you so much, sir. The last question is about addition of other drugs while managing heart failure along with the beta blocker. So you already have commented in your last few slides that as per the recent Canadian Pan-Indian guideline, all the remaining drugs like SGLT2 inhibitors, ARNI and beta blocker should be started at the same time.
Yes.
But one of the positioning statement presented by Dr. John McMurray and his team, they have written that it is first you need to start with beta blocker, and then without up titrating the beta blocker, within 1 week you add another drug, and accordingly they have mentioned 4 drugs. So what is your comment on this? What is your take on this?
It is almost same thing. 1 week is not much like 6 months as it was the previously it was taken. It used to reach that stage in 6 months. But 1 week is just to save oneself from so many over drugging and to save the patient confidence. So 1 week is almost same thing like trying all the drugs at the same time. So I agree with
Right,
you.
sir.
Yeah.
Sure. Thank you so much, sir. With this, we have come to an end of an academic feast. You have really very nicely given the take-home messages as well in your last few slides.
Thank you.
And all the questions have also been answered thoroughly. So I'm sure the audience who are really watching at this DGN must have got benefited with the kind of knowledge that you have disseminated on the beta blocker and heart failure management.
Thank you.
I would like to say thank you on behalf of Sun Pharma to Dr. A.K. Sinha for taking up this important topic and take us through the latest guidelines and the recommendations. I would also like to say thank you to all the audience and the physicians who have also taken out time from their busy schedule to attend to this academic feast. Thank you very much, sir.
My pleasure.
And hoping to see you again next time.
Sure,
Thank you so
my
much, sir.
pleasure. I will definitely like to take up the future CMEs. Thank you.
Sure, sir. Thank you so much, sir.
Okay.